All right. Hello, everyone. My name is Cassidy Ovula, and I'm the program coordinator for the Texas A&M Health Rural Engagement Program. A couple of things before we begin and I introduce our speaker. We are recording the webinar, and we will share a copy of the recording as well as a link to the slides with you. Give us a little bit of time to get that posted. I had mentioned earlier that we dropped a few links in the chat. Those slides will be included with the slides we send you from Patty on just a couple of resources that we have coming up. Any resources that the Texas A&M Health Rural Engagement Program provides are limited to clinics and hospitals in Texas. We would love to hear your comments and questions on the webinar, so please feel free to drop them in the chat as they come up, and we'll make sure to address them at the right time during the webinar. Additionally, we have set aside time for Q&A, and it is now my pleasure to introduce our speaker, Patty Harper. Patty Harper is a principal of Inquisi Consulting and technical advisor for the Texas Association of Rural Health Clinics. She has over 27 years of healthcare experience in the areas of healthcare finance and reimbursement, health information management, compliance, and practice management. Patty holds a Bachelor of Science from Louisiana Tech University, and she is credentialed through AHIMA with multiple certifications. She's also certified in healthcare compliance. Patty is a frequent speaker and content contributor for the national, state, and regional organizations on healthcare and other healthcare topics. Patty has served on the RHC board from 2018 to 2023, and we are so honored to have her here talking with us today. It is all yours, Patty. Thank you so much.
Thank you, Cassidy. I see a lot of familiar names and faces. So, welcome, everybody. It's a joy to be with everybody today. So, what we're going to do is go through some of the most recent survey deficiencies nationally and in Texas, and go through kind of a mini compliance crash course on how to avoid some of those deficiencies. And so, survey activity has really been slow to ramp back up coming out of the public health emergency. We do know, I know right now in Texas and in other states that we have accreditors that are out doing recertification surveys. We're still not hearing very much about state surveyors being out, particularly in Texas. So I know some of you in Texas, you're going on 6 and 7 years without a recertification survey, and a lot of things can fall in the cracks during that time. So we just want to make sure that we are getting a little camera here where I'm not so crooked. We want to make sure that you are aware of what the findings are and how to prevent them, and you can kind of do a self checkup on what is going on in your clinic. So nationally, so when we go by the federal fiscal year, we're going from October 1 to September 30th. That's pretty much how the CMS and all of the government agencies keep up with things. So in 2023, Texas had 58 RHC surveys, and in 2024, they had 53. And so far this year, for the fiscal period that started in October, we only have results from 4 surveys in Texas. So Texas has 363 rural health clinics, plus or minus. So that's not very much survey activity for that many clinics. And so if we look at what the top deficiencies are, we're going to look at 2023. The 2024 deficiencies were not comparable with what the national deficiencies are. And so 2023 aligns Texas particularly with the national survey deficiencies. And so all of this information comes from QCore, which I'll have a link for that website at the end of the slides for you. But if we look at it by category, when we look at rural health clinic compliance, there's several broad categories, and those are broken down into subsets of survey tags. So coming in equal at first and second are deficiencies revolving around environment and the physical plant of the clinic. And that is on par with deficiencies about emergency preparedness. This is not surprising in my own experience. These are exactly the way that we see deficiencies. We have 2 clinics in survey today. we had two clinics in survey yesterday. This is just Tuesday, right? Um, and then with also provision of services, patient medical records, and staffing responsibilities. So we do at least one plan of correction a week, if not more, for different people. So these deficiencies line up pretty well with what we're seeing nationwide. What we're going to do is dig into each one of these deficiency categories, and then we're going to talk about what the standard says, what the CFR says, and then we're going to talk about what the remedy for those deficiencies are. So I have 52 slides. We have an hour, so some of them I'm not going to camp out on. You are going to get these slides, so I'm not going to read regulations to you, but you'll be able to go back and see those. So if we start with the environment of the clinic, and a lot of times this is where a surveyor starts. First impressions are so important on environment. What they see, what they hear, what they smell the minute that they walk in your front door has a lot to do with how they approach the environmental survey. So if our clinic is just in terrible shape, we could get a condition level citing where we're not in compliance with any part of this section of this CFR. But what we see, these are some of the things that we see that the clinic, I'm going to give you at the top of the slide, you'll see the J tag that's coming from Appendix G. If you have a state surveyor, that is exactly what they are looking for. They have that Appendix G and they are looking for these survey tags. If you use an accreditor, they're going to have their own standards, but they are pretty much going to line up with or exceed what the J tags are. So I have given them here in the J tags. So we want your clinic to be well constructed. We want it to be free of hazards. And so this is a number one finding, that the overall condition of our clinic is not where it should be. Do we have adequate space? Is the clinic laid out in a way where it facilitates taking care of patients? Is it accessible? Are we free of any fall or trip hazards? Is it hazardous free in general? So we don't want any uneven floors. We don't want any carpet that could be tripped over, or rug that could be tripped over, cracks in the pavement leading up to the clinic. We want to make sure we don't have any slips or falls, and that our construction is up to code. So overall, we want our clinic to be in as good a shape possible. Now, I know we have clinics that are in old gas stations. They're in old Pizza Huts. They're in old buildings. They're in downtown buildings that your city or your county has allowed you to occupy space in. So sometimes we don't have a whole lot to work with, but we need it to be well constructed, clean, and safe. And so when you look around your clinic, you're going to want to look for these things as far as the overall construction. And so these are just a few examples of that. And then we're going to even dig a little further into making sure that our clinic has routine and periodic maintenance, not only of like the HVAC system, but also this goes all the way down to our essential patient care equipment. And so how do we prove that that we have a maintenance program? So one of the ways that we're going to prove that is that all of our essential patient care equipment has been inspected and tagged, and that we have a record of when a piece of equipment was taken out of service. We have a repair log. We know when that equipment was put back into service. So if you are a provider-based rural health clinic, this is something that may fall under things that your parent hospital does for you. But you as a clinic manager, you need to be making sure that those biomedical engineers are coming back around and they are inspecting your equipment and they're tagging it. Because it is going to be on you as the clinic and not them as the hospital if something is not like it should be. If you have a piece of equipment that is broken, it no longer works, you're waiting on a part for it, anything like that, you are going to want to mark that piece of equipment as do not use, and you're going to want to take it out of service. We don't want anybody grabbing that equipment and using it for patient care if it's not working. So, if you are an independent rural health clinic, you're going to have to contract with a company that will service your medical equipment. And those are sometimes hard to find. If you're having trouble finding one in your area, reach out to me. We may know of one that another clinic uses. This next deficiency is probably one of the ones we see cited most frequently, and it is that drugs, biologicals, and supplies are not appropriately stored. So we're going to see a standard that falls under environment for this, but we are also going to see another standard later on under a different category that's very similar. And so everything has to be stored according to manufacturer's instructions. It has to be used in accordance with the manufacturer's guidance as far as where we store that, the temperature, the lighting, keeping things in their original box until they are taken out to be used. Everything needs to be secure. Medications need to be locked. We don't want any medications in treatment rooms where patients are left alone. And so those are some of the things. This is where we're going to get in trouble for our open multi-dose vials that aren't dated. So you'll see my little yellow tag up there. These tags, you can get them on Amazon. They are very reasonable. You can also order them from McKesson or Henry Schein, all of those places. Your nursing staff needs to be trained, and it needs to become a habit that we are labeling multi-dose vials. One multi-dose vial unlabeled without a discard date on it is enough to fail your clinic survey, one of them. Now, it's the time of year where we are seeing a lot of respiratory illnesses, and you're going to be tempted to say, well, we're opening that Rocephin today, but it's going to be gone by noon, or we're opening that Decadron, it's going to be gone by this afternoon, and you're going to be tempted not to label it. And so one workaround for that is that you have a red basket in your nurse's station, and everything that is opened in that day is put in that red basket. And by the end of the day, someone will make sure it's labeled. So that's a workaround for that. We also want to make sure that anything that is marked single dose or single use, single patient use, that we are not using that. So sometimes we're tempted, once that top has been popped, to say, well, we only used a pediatric dose of that and we've got enough for another dose, but it is a single use vial. So that will also get you in big trouble. There are some supplies that are also single use, such as sterile packing and things like that. So we need to really pay attention to that. And then you'll see my little dot system over on this slide that actually came from the compliance team. That is just showing you that an inventory control system will be your friend. And so if you want more information about how to do an inventory control system, you don't want to have to be picking up that drug or that supply every 30 days to see the expiration date. I'm going to show you why it's hard to do that, because we're using new international labeling on our drugs, and we don't want to pick that up every time. We want to check that inventory into our stock, and we want to mark it in a way that every month we can just do a quick glance and find out what items are expired or potentially expired. And so this is probably one of the number one problems we see nationwide, is opened, unlabeled multi-dose vials or single-dose vials that we're trying to get a little bit extra out of them for our money. Both of those will land you in a lot of survey trouble. So these are our new international drug supplies, and I wanted to show you because these are going to be embossed on those little packages. So sometimes it's going to be white on white embossed on a box. So it's pretty hard to find those dates to begin with. We were at a clinic a couple of weeks ago, and we were pointing out the difference between the expiration date and the manufacture date. So you'll also see that if it's a single use supply, it's going to have a 2 with a slash through it. If it is an item that cannot be re-sterilized, it's single use and we're supposed to discard that, it's going to have a 2 with a slash through it and the word sterilize. So this is something you might want to do a little lunch and learn with your clinical staff on how to recognize these international symbols. Okay, I love this one. So this one is the premises are clean and orderly. So what is clean and orderly to me may not be what is clean and orderly to you. I am not necessarily a neat freak when it comes to my own house. I have a best friend who is a neat freak. So what is clean and orderly to you? And the same holds true to the surveyor. Every surveyor has their own personal opinion about what clean and orderly is. And so we need to be able to at least establish with them that we have processes in place to make sure that our clinic is kept clean. All of the evidence documents that you're going to be asked to give a surveyor, the purpose of those evidence documents is to evidence that you are compliant with your own policy. That's why we call them evidence documents. They are things that are going to support that you are actually following your own policy. So this is going to be the processes we use for turning a room around between patients. This is going to be our cleaning schedule of who cleans and what gets cleaned and what product is it cleaned with. And so all of this, as far as clean and orderly, can be very, very subjective. So it's very important for us to know our own processes. Under clean and orderly in Appendix G, oh my goodness, they include a bunch of things. And this Appendix G was updated in 2019 and they added some of these things. And so hand hygiene. We know now that the CDC recognizes alcohol-based hand sanitizer as being as effective or more effective than hand washing, except for when our hands are visibly soiled or we're dealing with something like C. diff, some infection that we actually need to be using soap and water for. Safe injection practices. If you haven't had a survey in a while, you may not know that the surveyor can actually observe your nursing staff giving an injection. And so sometimes, like we do at home, at work, in our clinic, sometimes we get a little bit complacent. Recently, we had a clinic that was cited because they were observing an injection being given and the nurse did not glove. And so it's very important that your staff knows the appropriate uses of PPE, particularly glove and mask and gowns and goggles, because they will be observed by the surveyor. We need to know how are we disinfecting and sterilizing things in our clinic. If you have an autoclave, you better be following that manufacturer's guidance to the T. If you're not, that autoclave needs to go into the trunk of your car. It needs to hide and go away because if you're not following those manufacturers' instructions for that autoclave, that can land you in not only disinfection and sterilization, but also infection control. Routine cleaning, that's where the cleaning schedule comes in. Who sweeps and mops? Who cleans the bathrooms? How often are those done? What happens if the housekeeping comes in the evening and we have a spill in the middle of the day? Who in our clinic is going to be responsible for containing that spill until housekeeping can get there? Everybody can clean a toilet, so if you see a toilet that's dirty, you should clean it. I'm in clinics. I have cleaned toilets in clinics before, so we all can do our part to keep things clean. Um, Disposal of waste and medical waste. So, red bag trash is a biohazard. So, we just can't have those red boxes just sitting around anywhere in our clinic. They have to be secured, they are a hazard. Food sanitation and pest control is something that was added to this section of Appendix G on the last revision. And they say even employee food areas, so everybody knows how junky a break room kitchen gets. And so we need to be aware that the surveyor can comment on that because it, again, gives the impression of our clinic not being clean. Pest control was added to Appendix G. Now, Texas has a state pest control notice where you are supposed to notify your employees of when your routine pest control service is being performed. That notice is in our Incudocs library if you happen to have access to those resources. Again, everything clean, orderly, well maintained, no rips or tears. Um, and with everything for the purpose of infection control, it's terrible. The respiratory illnesses are terrible right now. And so we need to really be making sure that we're not part of the problem of spreading infection, that we are doing everything to keep everything clean. Your exam tables, your upholstered furniture in your waiting room, no rips or tears. Those things cannot be properly disinfected. You can patch an exam table. You can temporarily put some type of a vinyl tape over it. But if it is a big tear or a scratch, then you are going to have to get that table recovered. It's really easy to get those recovered locally at an auto or a marine shop that can do that for you. The tiniest little braid area where my husband likes to call it fuzzies, where the fuzzies are sticking out, that cannot be disinfected. The tiniest little place needs to at least be patched. Larger tears need to be replaced. And then we want everything to be clean and orderly. I'm going to breathe a minute. I feel like I'm going really fast. Infection control. Um, we have to use hospital grade uh, wipes for cleaning down hard surfaces in our clinics. I have been in a clinic before where they were just using wipes from the dollar store. There was somebody that was using wipes from the AutoZone. It needs to be a medical grade wipe that kills all the big bad infections. And those wipes, like Santa wipes, very common. You'll notice the one on the slide has a 2 on it. That means that the wet time on that wipe is 2 minutes. So when I'm turning that room around, I take the dirty paper off, I wipe the table down. 2 whole minutes have to pass before I can put the clean paper back down. And so your clinical staff will need to be able to go through that process of turning the room around with the surveyor. Sometimes they know what they're supposed to say, but then the surveyor will watch them turn a room around and they will not be following their own process. Processes are what are very important in surveys. That's what gives the surveyor the confidence that you're going to stay in compliance. If you can prove you have a process, that you know that you intentionally are trying to accomplish certain things to meet the RHC conditions for certification. Hand hygiene, again, if you don't have sinks in the room, you need alcohol-based sanitizer in all those rooms. In a procedure room, you most definitely need a sink. And if your hands are ever visibly dirty or you're dealing with something very, very contagious like C. diff, then the hand sanitizer is not adequate. And then everybody knows how to use PPE. We all got a crash course in that during the public health emergency. We still need to remember that we need to glove and mask and have goggles if we're dealing with something like liquid nitrogen. Our next big area of noncompliance in rural health clinics is emergency preparedness. And guys, this is easier than it sounds. It's a lot easier than it sounds. So, emergency preparedness became part of a condition for certification a couple of years ago. It is 491.12. It's the very last condition for RHC participation that we have in the federal regulation. And there's a couple of really simple things to understand about emergency preparedness. So, there is where it is actually in the CFR. And when we're dealing about having an emergency preparedness program, there are four elements of an effective emergency preparedness program. You are going to be required to evidence that you have covered all four of these bases during your survey. So we're going to go through those quickly. First, you must have an all hazard risk assessment. Now, I know many of your hospitals are going to be using something that calculates probability, maybe that Kaiser Permanente spreadsheet that just makes my eyes go cross eyed. You just need to evidence that you have thought about what things could happen in your clinic and in your community that would require an emergency response from you. This has become the base of you creating your emergency preparedness program. And so you can use as complicated of a tool as you want, but it can be as simple as just everybody sitting around the table brainstorming what could happen, what has happened historically in our community, what could happen, and then figuring out which of these things are really the ones that we need to be prepared for that would have the most serious impact on our clinic or on our community. So you need a facility assessment and a community assessment. So two different assessments. Because your response to something that happens inside of your clinic is going to be different than your response to something that happens at the high school or at the football stadium or somewhere in your county that you're called on to help with. So it starts with an assessment, and that's the base of our plan. And then we have to, from the assessment, create our policies. Sometimes it's very easy to pull a template off of the internet and just use that template. And then we look at it and it doesn't have anything to do with what could really happen in my area. I'm not going to have a tsunami. If I am, in certain parts of the country, I'm going to have an earthquake, but certain parts of the country, I won't have an earthquake. So maybe next to your clinic, there is a chemical plant. Maybe next to your clinic, there is a gas plant. That is going to be a risk that is unique to your clinic. So we're going to build your policies to fit the unique things that you need to be prepared for. All of those policies and activation plans are going to go into your emergency preparedness plan. Now, your emergency preparedness plan can be a collection of policies, or it can be one combined document that includes everything that we're required to have. They don't all look the same. Some people will tell you they have to be in notebooks with tabs. Some people will tell you they have to be policies. So there's a lot of different ways to address this. And as long as we have all the required elements, we're going to have our emergency plan. The next thing that we need in emergency preparedness is a communication plan. Again, this is something that we really don't overthink. There are some people that we need to include in our communication plan or in our policies, and that's going to include our federal, state, and local emergency responders, our Office of Emergency Management. It's also going to include other RHCs and FQHCs who are in a proximity to us, as well as if we have tribal authorities. Not everyone has a tribal authority near their clinic, but if you do, you need to recognize that. If you have no tribal authority near you, your policy or your plan is simply going to say, we have not identified any tribal authorities in our area. Just because you don't have something doesn't mean that you ignore it in the plan. If it's a required element, then we're going to say we have no tribe or we use no volunteers. We don't want to just omit a section because it doesn't apply to us. We want to make it clear that we know it should be in there and it just doesn't apply to us. So when it comes to a communication plan, it's as simple as a call tree. You know, who is in command and what is the order of notifying people and how do we get in touch with them? So for our staff and our outside providers, we're going to want their cell phone. They're not going to always be at work when we need to reach them about an emergency. Same thing, we want to know all about our local, county, and state emergency management folks, fire department, police department, sheriff. At the county level, Texas has a great website that will tell you exactly who is in your region as far as emergency management. So we're going to want to know how to contact those. If we are provider based, our hospital probably already knows that, but we have to be redundant in that. We have to stand alone with our own emergency preparedness plan. We're going to talk about that a little bit more, but have a communication plan, have a phone list laminated and have it in the front of your EPP binder, or have it also posted near the main phones that people use. So a communication plan. We have to have an alternate form of communication. Hospitals are really big on having two-way radios. For smaller independent clinics, our cell phone is more than likely going to be our alternative communication. Then we move on to the last the last part of what is in an emergency plan, and it is training and testing. Now, guys, this is really easy to get confused. Training is education, testing is exercise. I get these confused all the time. Training is education, testing is conducting exercises, and we need to be able to evidence both of those. So, ways that we might train during we have an emergency preparedness training checklist that we give our clinics so that everybody knows where the EP binder is stored, where the fire extinguishers are, how to operate a fire extinguisher, what are the evacuation routes in the clinic. And so we just have a general checklist to orient them to basic emergency processes. Then we may also want to do more formal education. We may want to have a quiz after we have done a tabletop exercise. We might want a general emergency preparedness quiz as part of our orientation process. These would all be things that are EPP training. Again, training is education and testing is events. So even though we're taking a test, it's training. Even though we're doing an exercise, it's testing. Those are very easy to confuse in my own mind too. So this is what the CFR 491.12 says, and I did a 1, 2, 3 on them. So we have to have testing, a testing exercise, a community-based or a facility-based every 2 years. On the alternating years, we have to have a tabletop or some other exercise of our choice. And then either with a tabletop or with a full facility-wide exercise, we have to have an after-action report. So another way to do it is we put it in this little graphic that every 2 years we're going to have a community or a facility-wide testing event or an activation. So if you actually have something happen, like the really severe weather that we had about 3 weeks ago, maybe you had to close your clinic, maybe you had roads that were not passable, you had other conditions with your patients because of the weather, then we have to activate our severe weather plan. Anytime we activate our plan, it takes the place of our full scale exercise. We have to document everything that we did, and we have to put it in an after action report. And then on the opposite year, we're going to do a tabletop or another event of our choice. And again, we have to do an after action report. We have to document it. I'm thinking I did not put a copy of an after action report in these slides. So that was an omission on my side. This is a document that's put out by Certain Survey, which is a part of CMS. And it's just a little timeline. The dates are old, but if we had an exercise of our choice, then the next year we would have to have a full scale exercise. If before that full size scale if after that we had an emergency activation, it gives us an out on our next full scale exercise. We still would do our exercise of choice the next year, but the next full scale exercise that is waived since we had an activation. So this is so important. If you've ever heard Jeff speak, he's always talking about, you guys, we have this happen all the time. We just need to document. We lost power, we lost internet, we had a closure because of weather. We were on lockdown because of something else that was going on in the community. So that's why we need to make sure that we document whenever something happens in between our normal scheduled exercises. Okay. But my hospital takes care of all of this for me. I don't have to take care of it. I'm a provider-based, hospital-based clinic. My hospital has got me covered. They probably don't. I'm afraid, I'm sorry to say that, but they probably don't. An RHC is not a department of your hospital. It is a separately certifiable standalone CMS facility. And the RHC has to meet all of the EPP requirements for rural health clinics, which are different than the requirements for a hospital, for a surgery center, for a dialysis center. So your hospital may have the hospital plan worked out. They may not know what is unique to you as a rural health clinic. So we can have an integrated plan. That's what this section of the reg is about. But your RHC plan and all of your RHC documents are just a chapter in the big hospital's book. The hospital's book doesn't cover you unless you have your own chapter. You have your risk assessments. You have your own call tree. You have your own activation plans. You have your own exercises. You have your own after action reports. And so if you might want to check with your hospital and make sure they know that your RHC requirements for emergency preparedness are different from your hospital ones. Also, if your RHC is not on campus, if you're near a railroad track or a major highway, or like I said, you have a fertilizer plant near your rural health clinic, that's going to be a risk to you that may not be a risk to the hospital. So your risks have to be unique to your location and to how your clinic does business. This is just a little slide that talks about some common compliance issues with provider-based clinics when it comes to emergency preparedness. We get all of our emergency preparedness guidance from Appendix Z. And Appendix Z goes through and it talks about every requirement. It's not until the bottom of each section that it tells you which facilities are exempt from that requirement. And sometimes we stop reading before we get down to the part that says rural health clinics are not required to do that. So rural health clinics do not have to have food. They do not have to have blankets. We don't shelter in place the same way that a hospital does. And so that's where we'll see these differences between the hospital requirement and the clinic requirement. So your clinic management should participate in the development of your own emergency preparedness plan, including your risk assessments. Any questions so far, Cassidy?
Not yet, Patty.
Not yet. Okay. All right. I know I feel like I'm blowing through this. Okay. The next area of deficiencies are provision of services. I always think this is worded kind of weird. A lot of it involves our patient care policies. Um, and our policies around, again, remember I told you there was going to be another area where we were going to hit on drugs, rules for storage, handling, administration of drugs. So we must have written policies. So we may be doing all those things that we talked about, storing the drugs appropriately, labeling the drugs appropriately, but we have to have written policies that reinforce those processes and procedures. The drug policies or drug policy, we just have one. It has to include proper storage, proper environmental conditions, the security of drugs. So all of our drugs have to be locked or in a locked med room or in a locked cabinet, not in patient treatment areas. If we're using controlled substances, we need record keeping, those controlled substance logs of as we draw down those doses, that we account for everything that was in that vial. This also includes testosterone and patient supplied testosterone. Those are controlled substances. Again, how we're handling the drugs and biologicals. We don't really think of clinics as compounding. We do have a few rural health clinics that mix their own allergy extracts, and they have to have compounding, an area for compounding that meets all of the pharmacy requirements for that. We may not think that we're compounding, but there may be special instructions for reconstituting a product and how we're going to handle all that. And again, safe practices when it comes to administration of drugs. My goodness, we were in a clinic in Mississippi, and I was watching the provider actually came in to draw their own medicine up, and she never looked at the syringe. She just pulled the plunger back and filled the syringe, and she never looked at the dose. And I questioned her on it. I'm not clinical, but I'm like, this does not look right to me. And she said, oh, I've done it long enough. I know what it feels like when I draw up a cc of something. That should make you a little worried that she's doing it by feel instead of actually checking the dosage that's being drawn. But all of our policies are going to cover all of these areas. It can be multiple policies. We have it in one policy. It's probably the lengthiest policy that we push out, but we do have to have a written policy that covers all of those areas. Staffing and staffing responsibilities. This one is pretty low for Texas. That's why I have it at the back of the slide deck. Sometimes this is really a big problem, but we're going to hit on a couple of things that are normally cited. Believe that I got a slide out of order. I am so sorry. Okay, let me move on. So staffing. The staff is sufficient to provide services. So do you have adequate staffing? Do you have enough providers and enough nursing staff, enough front desk for the volume of patients that you see? We must have a physician, a nurse practitioner, a physician assistant, a certified nurse midwife. We must have a qualified RHC provider in the clinic all of the posted patient care hours. So if your clinic is supposed to be open, if your sign says that you are open from 8 until 5, then you must have a provider in the building to provide services during those times. We find this to be a big problem. It gets slow in the afternoon, so the provider goes home. We don't have appointments in the afternoon, so somebody is sneaking out the door because they have travel ball and they want to get on the road. We must have a provider in the rural health clinic all of our posted care hours. Now we can have admin hours posted when people can come into the lobby, they can come to the front window, they can make an appointment, they can pay a bill. They're not allowed back into the treatment area of the clinic, which leads to our other requirement in Appendix G is that no medical services done without a provider in the clinic. That's blood pressure checks, that's lab draws, that's injections, that's allergy shots. I have to have a provider in the building. Now, that doesn't make a lot of sense to some new clinics because if I was a regular medical office, yes, I'm going to come in and get that lab draw or get that allergy shot. Rural health clinics are supposed to be first responders. Our rural health clinics are supposed to be where someone can go for emergency care. So during our posted hours, somebody has got to be there. The exceptions are going to be national and state holidays. If you are caught off guard without a provider, you need to notify patients that you don't have a provider. You need to put a sign on the door that says no provider. You can get care at the next closest clinic or hospital. Again, no patient care services behind the waiting room door or in the treatment area if there's not a provider. I'm going to go back because there's part of this regulation that's a little bit under debate right now. It says that we can have one of our mental health professionals in the clinic during patient care hours. There's other CMS documentation that conflicts with that and says that we have to have a primary care provider in the clinic during the open hours. So I will tell you there is some discrepancy in the guidance we have some for CMS. We pretty much guide everybody to have a primary care provider, with the exception of maybe your mental health professional is taking evening appointments. If that's true, I would probably put something that says mental health appointments, mental health services by appointment. And then I would put a sign on the door that said no primary care if you did not have a primary care in the building at the time. That's my interpretation of it. That's not actual formal guidance. Okay. The other thing that we get in trouble with staffing is, and this is usually with provider-based clinics, is that the physician, along with the physician assistant or nurse practitioner, participates in the development, executing, and reviewing of the policies for that clinic. So if you're a hospital-based clinic and you have a policy committee, you have a compliance committee, and they are creating your policies, you are not in compliance unless that medical director and at least one of the NPs or PAs is actually participating in that development and in the reviewing of those policies. So again, a rural health clinic is not a department of the hospital. It has to stand alone on this requirement. And so, what we like to see to evidence that is a policy development and review attestation that is signed once every 2 years by the medical director and at least one of the APPs in the clinic and an outside reviewer. That outside reviewer can be your consultant. That outside reviewer can be someone in your community that is knowledgeable about healthcare practices, a pharmacist, a therapist. It can also be somebody within your greater system that does not work in the clinic. And so we must have that. This usually lives in the very front of your policy and procedure manual. If you have a paper hard copy one, or it is something that you have that you can show the surveyor to evidence that the review process happened. Okay, we are coming up on the end. Patient records. And this kind of says that we have to have a complete medical record on all of our patients. 49110 tells us what a complete record is. So we're going to have demographic information. We're going to have pertinent medical history. We're going to have all of those things that we get with the intake forms for a new patient. The number one deficiency is we can't find the consents. We know we got them. The patient signed that consent. It was in a stack to be scanned in. It didn't get scanned into their chart. It got scanned upside down, and we have a blank copy in the chart. They're signing the electronic signature pad, but we don't know where in our system that information is stored. So when the surveyor asks us, we can't find it. So consents to treat in Texas and in most states are good until they're revoked. So it's best practice to get a consent every year. If you're part of a hospital system, they may be having you get consent for every visit, just as if it was an outpatient department visit. Not necessary, but that may be your practice. So no consent forms is probably the number one thing that we see. We may have them, but we don't know how to retrieve them to show the surveyor that we have a consent. A thing that's a hot topic right now is lab test results and evidence that the patient was notified of abnormal or critical value lab results. And so that's really with the accreditors has become a very hot topic. We revised our policy on that to meet the surveyor's expectations last year. So just making sure we have a process for notifying patients of results. If those results are normal, it may be your provider's discretion not to call them. They may have said, we're going to call the patient if they're abnormal. We at least need to know that those lab results were looked at and were reviewed in some evidence of that. So these are the things that are in a complete record. Consents, proof of physician review. So our medical director is responsible for reviewing a certain amount of APP charts. Even in a state like Texas, where NPs have independent practice, it's a federal RHC rule that we still have to have physician review of APP charts. And then proof that we are auditing those medical records to make sure that they are complete. And this is an example of what that medical record completeness audit would look like. We're just checking off to make sure that everything, if applicable for that visit, is in the record. You want to do this quarterly just to make sure that nothing is falling in the cracks, and that if you are seeing that things are missing, that consent is not able to be easily located, you're going to want to retrain on that or come up with a new process. Okay, we're going to go through some of the resources that we talked about. The RHC conditions for certification, the federal regulation is CFR 42 CFR 491. So there's 12 conditions of certification. We addressed several of those in the deficiencies that we covered today. QCore is the website that we got the survey data from. It's a public database. You don't have to have a special access to it. You can go out and see what your competitor, the deficiencies that your competitor had on their last survey. They can see what your deficiencies were on your last survey. So we want to make sure that there's a lot of good data out there, and you can slice it and dice it in lots of ways. Appendix G is the state operations manual for state surveyors. All of the J tags we talked about today come from the state operations manual. If you have an accreditor, they are not going to use those J tags, but they're going to have their own standards that have been approved by CMS that parallel Appendix G. Appendix Z is where we find all of the emergency preparedness requirements for every type of certified healthcare facility, including rural health clinics. And then our best place for us to go to interpret the 491 reg is the Benefit Policy Manual, Chapter 13. Y'all have heard me say this. If you all read Chapter 13, I would not have a job. So you want to bookmark it on your computer. It's your easiest place to find 99% of your answers about rural health clinics. So here are all of these resources. I think we have about 5 minutes for questions. I don't know if I just blew through that too fast or not. Um,
That was
so questions and comments. And then this is my contact information. That is my email, my cell phone, anything that you send to that email address or when you call that number, you get me. So I will answer any questions as follow up to this webinar as we always do.
Thank you so much, Patty. That was there was a lot of great valuable processes and tips and stuff in there. We do have a couple of comments in chat. I'm going to scroll back up. So Brooke says, do most RHCs have administrative hour during lunch? She's just trying to figure out the best way to handle that.
So yes. So if you aren't going to have a provider during lunch, like either you're closing and going out for lunch, or if you don't have a provider at lunch, then you will want your lunch hours posted separately than your patient care hours. So if it says 8 to 5, we're assuming then you have a provider at lunch. If it says 8 to 12 and 1 to 5, then we're assuming that you have a lunch hour. So there's a bunch of different ways to display that. But yes, if you do not have a provider who could see a patient at lunch, then you do need to block out your lunch hours as admin time or as closed time.
The next question states, if the medical director co-signs charts for the MP, is that qualified to be a physician review of the chart?
That's a great question. So, yeah, yes, sort of. But the surveyor is going to want to see the exact charts that were reviewed. So if your EHR allows you to run a co-signed report, and for the month of February, you can pull all of the co-signed charts, then that should satisfy the surveyor. The fact that they go in and look at them and sign them, but we can't specifically identify those encounters to be able to show the surveyor specific charts that were reviewed. You also will want some kind of review criteria for that. I know that co-signing is one of the easiest ways for them to do it. Co-signing obligates the supervising physician to that medical care. So a review that is just a quality function review, which they're just using an audit form, is a quality function, does not hold that provider liable for that care. So even though co-signing, and I do believe we do have to co-sign for physician assistants in most states, but for nurse practitioners, we don't have to co-sign. That medical director needs to know when he co-signs that chart, he is making himself liable for that care, as opposed to if he doesn't co-sign it, but he does a quality review of that chart, then there is no liability on that provider because quality functions are not discoverable. So that may be a little bit in the weeds for everybody. If you have a question about it, you can email me. But yes, co-signing, as long as we can identify which charts were co-signed and we have criteria for what the review was. We also need to be able to show that there was dialogue back and forth between the physician and the APP. Why did you give that antibiotic? Well, I gave that one because of this. Well, we would have rather you gave that one instead. So if there's any dialogue or collaboration, the surveyor will want to see that that process is in place. Many of our EHRs will document that dialogue. If not, we will just need a signature that everybody worked on that chart review together.
Okay, she says thank you for the reply. Any other questions? We still have a minute, so you definitely have time if you have a question. I do want to say a couple of things. We will share the recording as well as a copy of the slides with you following the presentation today. You'll have to give us a little bit of time to get that posted, but we'll send that out. And Okay, let me pop back over because we had another question, Patty. Does it count for the provider to be in the hospital if we are attached?
Does it count for the provider to be in the hospital? So I'm guessing that that's saying, is that provider considered to be in the clinic if he is under roof at the hospital? And the answer is no. There needs to be a provider within the four walls of the clinic, all of the patient care hours. The only exception would be is if that RHC provider is also on call for the emergency room for the hospital and they are called out because of a trauma that's coming into the ER. In that event, there are no patients left in the treatment area while the provider goes over to the emergency room. So if they're rounding, they're not in the clinic. If they're in the emergency department, they're not in the clinic. If they're delivering a baby, they're not in the clinic. So I must have a provider in the clinic all patient care hours. It doesn't have to be the provider that the patient is going to see. It just has to be a provider. So generally the answer is no to that.
Great, thank you. Okay, and we'll still take a couple of questions, but I'm going to go back to what I was saying a moment ago. We will share the slides and we will share a couple of other slides about some upcoming resources that we have. I also wanted to let everyone know that if you're a rural health clinic in Texas and you would like additional information on receiving survey preparedness support from INQUISEEK and Patty and the Rural Engagement Program, please reach out to us. I dropped the Rural Engagement Program email address in the chat, as well as a form that we have that allows you to request technical assistance. So we are able to provide that support to eligible clinics that are in Texas at no cost. So we would love to chat with you about whether or not that's an option. And then we still have another question coming through. Provider out ill or on vacation and no other provider to cover. Just post a sign.
Oh, okay. uh, oh, Kelsey's helping me out. Great. So, it should rarely be that you're without a provider. So it's going to be an unscheduled absence. So if you're a small rural health clinic and you have one nurse practitioner and you want to go to the beach, you have to have a backup provider for your clinic. Again, we have had situations where surveyors show up for recertification surveyors and for a recertification survey, and the clinic is closed, locked up, tight as a drum, lights off, nobody home. That does not go well because you are supposed to be open all of your patient care hours. Um, if you're going to be closed the day after Thanksgiving, you're probably okay to put a sign on the door. If you're going to be closed Christmas Eve, you're probably okay to put a sign on the door. If you don't have a provider there, you do want a sign on the door where they can get care, a phone number they can call. But that a sign on the door doesn't mean we're always right in not being there. So I can't leave and go to the beach for 4 days and put a sign on the door. But if I am not there, I need a sign on the door. So it's a real challenge for small clinics that maybe just have one provider.
Excellent. Okay. I think that's all of the questions. If you have a question that you did not submit, please reach out to Patty or me or anyone at the Rural Engagement Program and we'll get an answer for you. I did just launch a poll. If you have a moment just to complete that, we would appreciate it. We thank you so much, Patty. You had some really fantastic information and it's always a pleasure. And thank you to everyone that attended and we will see you back here next month. Bye, everyone.
Thank you for having me. Bye bye.
Bye.